Professor of Pediatrics at Institute of Child Health and Hospital for Children at Chennai. Now, I welcome all the participants to this distant learning program. Yes, now let us see the first slide. Today's topic is HIV and TB. Slide. Yes, we all know tuberculosis is caused by the Mycobacterium tuberculosis. The Mycobacterium tuberculosis, as you all know, is otherwise called as acid-fast bacilli. Acid resists decolorization with acid when stained with the AFB staining or Aramine staining. Yes, tuberculosis mainly spreads through droplet infections. The infected person, when he coughs or even speaks or he sneezes, he discharges a lot of droplets containing the tubercle bacillus, which may infect the nearby persons. The organisms enter mainly the respiratory tract or the gastrointestinal tract. In the respiratory tract or gastrointestinal tract, after gaining entry, they go and settle and form a small primary focus. The organisms are taken up by the macrophages, but the macrophages are unfortunately unable to kill them. These bacillus, they multiply inside the macrophages, and a small granulomatous inflammation is set up at the primary site of infection, and this is called as a primary focus or a gone focus. Yes, when this primary focus, from the primary focus, the inflammatory process may extend to the local lymphatics through the draining lymphatics, and the local lymph nodes also may be involved. So, the primary focus, the draining lymphatics, and the enlargement of the draining lymph nodes together constitutes the primary complex. It is called as primary complex, otherwise called as a gone complex. At this stage, many times patients are asymptomatic, or non-specific symptoms like fever, lassitude, night sweats, anorexia, cough, sputum, erythema nodosum may be present, and many times they are sputum negative. The acid-fast bacilli are difficult to demonstrate in the sputum, but sometimes it may be positive. And sometimes the primary focus will be set other than the respiratory tract, mostly in the gastrointestinal tract, that is at the ileocecal junctions with nodal enlargement in the peritoneum or vomentum. This is the commonest next primary complex other than the gone focus in the lungs, gone complex in the lung. Yes. Am I audible to all of you? Yes. And now we are seeing the primary tuberculosis. What is post-primary TB is if the infection is not contained with the primary complex due to some or other reasons like comorbidities of malignancy, diabetes mellitus, immunocompromised state secondary to steroid intake, debilitations, and other lung lesions. The infection is not contained within the primary complex, and the primary focus expands. To form a local consolidation, or the organisms from the primary focus may be discharged into the draining lymphatics or the blood channels to be spread to the distant organs. The spread of the tuberculosis throughout the lung is called as the miliary tuberculosis, and the seeding of the bacillus to various organs and their multiplication in various organs of the body is called as disseminated tuberculosis. Yes. And these are the common symptoms of pulmonary tuberculosis. Many times, at least in initial phases, it is silent, means asymptomatic, or may be associated with cough, expectoration, malaise, weight loss, night sweats, very rarely hemoptysis, and fluid collection in the pleural cavities, pleural effusion. Yes, these are the different parts of the body may get involved in the process of tuberculosis. Look at the middle ear may also not be spared. This is the involvement of the tonsils and the lungs, pulmonary tuberculosis, and rare pleura may be involved, and rarely the pericardium also may be involved. CNS involvement, brain and the meninges may be involved, and the iliopsoas abscess, bone tuberculosis, adrenal gland, the ureter and the bladder, and the liver, spleen, and the peritoneum. All these organs, and the genitourinary system, like the genitals, especially the epididymis, and the fallopian tubes in females, any organ, no organ is spared in the body. Yes. See, this is the definition for miliary tuberculosis. Miliary tuberculosis follows a hematogenous dissemination. Clinical features again are non-specific. X-ray chest may show a reticulonodular shadowing, and biopsy of the lung is rarely needed to diagnose this. But biopsy is needed in extrapulmonary tuberculosis. Yes, the draining lymph node may be biopsied, or bone marrow may be aspirated in disseminated tuberculosis. Meningeal tuberculosis, the onset is usually subacute and with meningitic symptoms like severe headache, fever, nausea and vomiting, and characteristic neck stiffness and photophobia. The genitourinary tuberculosis usually manifests as dysuria, loin or back pain, hematuria, sterile pyuria. Renal ultrasound may demonstrate the lesions, some of the abnormalities we can actually see with the ultrasound probe. And renal TB may spread to bladder, seminal vesicles, epididymis, or the fallopian tubes. Yes. Again, the bone TB, tuberculosis can involve the bone, especially the vertebra. When vertebra is involved, it leads to collapse, fracture of the vertebral bones with abscess formation. This is called scald abscess formation along the vertebral column. It's otherwise called as pot spines. X-rays and biopsies are diagnostic or confirmatory tests. Skin TB, the skin also may be involved in the form of jelly-like nodules. It is called as lupus vulgaris. They are mainly seen in the face and neck. The pericardium also may be involved, as I have shown in the picture, with exudative tuberculous lesion. It is called exudative pericarditis. Chronic pericardial effusion and constrictive pericarditis can also occur due to chronic granulomatous inflammation. Fibrosis and calcification may be prominent with spread to myocardium, and this condition warrants steroid therapy of at least for 11 weeks duration with anti-TB medications. And this is the macroscopic appearance. You can see a granuloma with central caseating necrosis, which is very characteristic of tuberculous granuloma. This caseous tuberculosis, caseous necrosis is surrounded by lymphocytes, epithelioid cells, and multinucleated Langerhans cells. It constitutes the typical tubercle. That's why it is called as tuberculosis. Yes. So when to suspect tuberculosis? These four symptoms are very, very characteristic, and these four symptom complex are more specific and sensitive, If any one or more of symptoms are not present, we can boldly say these patients may not have tuberculosis. The four important symptoms are cough, chronic cough, loss of weight, night sweats, and fever. In children, there may not be the symptom of night sweats, but there will be current cough, loss of weight or failure to thrive, there will be fever, and there will be a history of contact with tuberculous patients. The night sweats are not usually seen in pediatric patients. Yes. Next, the diagnosis of tuberculosis. When we suspect a patient with the tuberculosis, these are all the investigations will give some clue about the diagnosis. The important investigations are sputum examination, X-ray chest, Mantoux test and CB at a cartridge-based nucleic acid amplification test, sputum culture and sensitivity, and fine needle aspiration cytology. Yes, chest X-ray, even though is not very specific for the diagnosis of the tuberculosis, it is a very useful tool in screening patients with tuberculosis. Many times it shows abnormalities, but sometimes, very rarely, even with the X-ray chest may be completely normal in a smear positive patients. Yes. This X-ray shows consolidation, cavities, fibrosis, and calcifications seen in the middle and lower zones. But in pulmonary tuberculosis, mainly the upper lobe will be involved. Yes. How to treat tuberculosis? There are first line drugs and second line drugs. The first line drugs are mainly bactericidal. They are Isoniazid, Rifamycin, Pyrazinamide, Ethambutol, Rifabutine or Rifapentin. The second line drugs are Streptomycin, Cycloserine, Para-aminosalicylic acid, Ethionamide, Amikacin or Kanamycin, Capreomycin, Levofloxacin, Moxifloxacin and Gatifloxacin. Yes. So these are the common abbreviations we use when we prescribe. EMB for ethambutol, INH for isoniazid, PSA for pyrocinamide, RIF for rifampicin, and RPT for rifampicin, and SM for streptomycin. So these are the regimes followed in RNTCP, Revised National Tuberculosis Control Program. This is the regime we follow in RNTCP. Yes. Yes. We categorize the patients with the tuberculosis into category 1 and category 2. What is category 1? Any new patients with sputum smear positive, or any new patients with sputum smear negative, or any new patients with extrapulmonary tuberculosis. They are categorized as category 1, and we start the regime 2H3, R3, Z3 and E3 plus 4H3 and R3. This means 2 months of intensive phase with 4 months of maintenance phase. In the intensive phase, we give INH, rifamycin, pyrazinamide and ethambutol 3 times a week. 3 times a week, totally for 2 months. And the maintenance phase, we give only 2 drugs, INH and rifamycin, each 3 times a week for totally 4 months. This together constitutes the category 1. This is the treatment regime for category 1. What is category 2? Category 2 is nothing but patients with relapse and or sputum smear positive, or patients with positive smear with treatment failure, or patients who are on default but they come with a positive sputum smear. So, and others, other than any patients other than category 1, we can categorize them into category 2, and we will start this category 2 regime. Category 2 regime, the total duration of category 2 regime is 8 months instead of 6 months in the category 1. We treat them for 8 months. Here we give 5 drugs in the initial phase and 4 drugs for 1 more month, and then 3 drugs for the next 5 months. For the first 2 months, we give INH, rifamycin, pyrazinamide, ethambutol and streptomycin, all 3 times a week. And this is followed by 4 drugs, INH, rifamycin, pyrazinamide, ethambutol, all are 3 times for a week for 1 month. This is followed by 3 drugs, INH, rifamycin, ethambutol, each 3 times a week for the next 5 months. Yes. Any doubt? Yeah. This is the regimes we use for the extrapulmonary tuberculosis, like the TB meningitis, TB spine, and other forms of like abdominal tuberculosis and other forms of extrapulmonary tuberculosis. Question varda? Category 2. இதிலே சொல்லிடலாமா? இல்லாட்ட என்டர் பண்ணுமா? ட்ரை பண்ணுமா? Yes. And the sputum negative relapse, we can go to the previous slide. Yes. Yes. Again, if it is a relapse, we can start category 2. Category 2. Question. Yes. Yes, this is the dosage of various drugs for adults. Isoniazid 600 milligram, 300 milligram tablets, 2 tablets, or rifamycin 450 milligram, 1 capsule, pyrazinamide 1500 milligram, 750 milligram tablets into 2, ethambutol 1200 milligram, 600 milligram into 2, and streptomycin, if we give, it should be given as injection IM 0.75 grams intramuscular injections. And rifabutin and rifampicin are the new drugs. For patients receiving medications having unacceptable interactions with the rifampicin, we can switch over to rifabutin. And rifampicin can be used once weekly for HIV negative adults with drug susceptible non-cavity tuberculosis and negative AFB smears at completion of initial phase of treatment. The new drugs, the fluoroquinolones, levofloxacin and moxifloxacin and gatifloxacin, the fluoroquinolones, are specially used when there is when the first line drugs are not tolerated, or the strain resistant to rifamycin, isoniazid or ethambutol, or when there is evidence of other resistant patterns with the fluoroquinolone susceptibility. So, treatment of pulmonary tuberculosis. A good compliance is necessary. It helps cure the patients and prevents spread of resistance. Before treatment baseline, Bacteriostatic. Definitely bacteriostatic. Yes. Am I audible? Yes. And isoniazid, the mechanism of action is not well known, but it is believed it inhibits the mycolic acid synthesis, resulting in disruption of the bacterial cell wall. And this is the most effective bactericidal agent, and this drug is involved almost in all the regimes. Pyrazinamide is bactericidal and is active against intracellular dividing forms of Mycobacterium tuberculosis. Main effect only in first 2 to 12 months, that is the intensive phase of the TB treatment. It may be it is very much useful in TB meningitis as good meningeal penetration is seen. Ethambutol is a drug which is bacteriostatic, and streptomycin is very rarely used when there is resistance to isoniazid is established. Yes. Again, the continuation phase is for 4 months and we require 2 drugs, that is INH and rifamycin. If there is resistance, we can use ethambutol. Drugs best given as combination preparations unless one of components cannot be given. The drugs they come in combinations and they can be very well utilized. The LFT should be monitored as the INH and rifamycin are hepatotoxic. If no liver problem, we need not have a baseline liver function test. If any pre-existing liver disease, alcohol abuse, need frequent liver function tests, especially in the initial phase. If no liver problem, further checks necessary only in if there is fever, malaise, nausea, vomiting, jaundice and deterioration in the clinical condition. If the AST or ALT is more than 2 times of the normal value, monitor LFT until normal. If the ratio is 5 times more than the normal or the bilirubin level is very high, we can stop anti-tuberculosis medicine for a brief period. If the patient is not unwell and non-infectious, TB treatment can be stopped until LFT becomes normal. If patient is unwell, smear positive, need inpatient treatment until LFT becomes normal and we can start streptomycin and ethambutol. Once LFT is normal, challenge dose of original drugs sequentially in order. Isoniazid, rifamycin, pyrazinamide in sequences can be started with monitoring of patients and clinical conditions. The query if any queries you know, note it. Huh? Yes. So if there is renal or liver failure or pregnancy, we need specialist advice to continue the management of tuberculosis. Sponsored by. Huh? Am I audible?
Okay then program? Okay then.
Yes. So what are the side effects of the anti-tuberculosis drugs? The rifamycin. The commonest side effects are hepatitis. Small elevations in AST are acceptable. Stop if bilirubin also goes up. Orange urine and tears and contact lens staining, inactivation of oral contraceptive pills, flu-like syndrome, thrombocytopenic purpura or other side effects of rifamycin. Hepatitis, peripheral neuropathy, pyridoxine deficit, agranulocytosis, and rarely psychosis are the main side effects of isoniazid. Optic neuritis is the complication or side effect of ethambutol therapy. Hepatitis, arthralgia, hyperuricemia are the side effects of pyrocinamide. And gout is a contraindication for pyrocinamide therapy. Yes, the antituberculosis drugs may interact with other drugs. This fact should be borne in mind when we treat patients, especially with HIV, as rifamycin is a hepatic enzyme inducer. Therefore, it decreases the levels of oral contraceptive pills, corticosteroids, phenytoin, sulfonylureas, anticoagulants, methadone, and the ART drug protease inhibitors. Whereas isoniazid is a hepatic enzyme inhibitor. Therefore, the levels of carbamazepine, phenytoin, and anticoagulants may actually be increased when we concomitantly administer isoniazid and these drugs. So let us see something about the tuberculosis in HIV patients. Yes, this is the incidence of tuberculosis. The incidence is very high in patients who are manto positive. HIV patients are at an increased risk of developing tuberculosis. They develop active tuberculosis once infected with Mycobacterium tuberculosis, and reinfections also are more common in patients with tuberculosis. And relapse that comes after stopping the treatment for some time also is very common in patients living with HIV, and the mortality is much more in patients with tuberculosis and HIV. The estimated burden of HIV among TB patients is 4.78% in India. Yes. So the manifestations of tuberculosis in patients with HIV infections may vary with the phase of the HIV infections. In early phases, the clinical presentation often resembles post-primary tuberculosis, that is adult type of tuberculosis with cavity formation. And the sputum will be often positive, and chest X-ray appearance often shows cavities. Whereas in patients in late phase, Primary tuberculosis manifestations are common. The sputum will be often negative and the presentation, the atypical X-ray chest may show atypical presentations, often infiltrates, mid and lower lung field lesions, intrathoracic lymph nodes and cavities are very infrequent in yes. Yes, these are the chest X-ray pictures, courtesy to Tambaram TB Center, Tambaram Center. Yes. So, as the CD4 cell count falls, the lesions becomes more and more marked and there is a diffuse involvement. Yes. Yes. This graph shows the increased sputum smear positivity in HIV negative patients and early phases of HIV. As HIV advances, the sputum smear microscopy become increasingly negative. Increasing. Yes. This is the diagnostic algorithm of tuberculosis in patient with HIV infection. Yes. So whenever we suspect, we do 2 sputum smears and X-ray tests. If 1 or 2 sputum are positive, we can categorize them as smear positive TB patient. Smear positive sputum. If 2 sputums are negative for acid was bacillus, but X-ray suggestive of tuberculosis, again this patient is categorized as sputum smear negative tuberculosis. Sputum smear negative tuberculosis. And both sputum smears are negative and X-ray is not suggestive of pulmonary tuberculosis. We categorize them as non-tuberculous patients and we don't start any antituberculosis drugs. Similarly, in extrapulmonary tuberculosis also, we take smear or culture positive specimen from extrapulmonary sites. We can aspirate a lymph node. We can take biopsy from the granuloma from the affected organ and we can look for the acid bacillus and we can grow them in culture medium also. And if positive, we can say this is extrapulmonary tuberculosis and we can start antituberculosis treatment. And if the cytohistopathological examination is suggestive of a tuberculous lesion, again we can start antituberculosis treatment. Or they may show some other evidences like a positive X-ray chest result and other radiological examinations revealing a positive tuberculosis infection. Here also we can start antituberculosis treatment. Yes. So these are the components of management in HIV TB patients. Anti-TB drugs per RNTCB schedule. We follow only the revised National Tuberculosis Control Program schedule. We should always evaluate for the presence of other opportunistic infections. We should concomitantly start cotrimoxazole prophylaxis also. The nutrition should be ensured. The other family members should also be screened for HIV and tuberculosis. Start antiretroviral therapy if appropriate as per national guidelines. Answer. Yes, see the response to anti-tuberculosis treatment is very good. There is clearing of the infiltrations after 6 months of anti-tuberculosis therapy. The outcome of tuberculosis in HIV infected patients depends upon the host factors like the CD4 count at the time of ATT initiation and the immune status, and the immune status may deteriorate even while on anti-tuberculosis treatment if the patients are not started ART along with tuberculosis with anti-TB drugs. And it mainly depends upon the associated opportunistic infections at the time of diagnosis and at the time of initiation of therapy. Anti-tuberculosis treatment outcome without ART results in a high mortality, and relapses and reinfections are more common in patients with HIV who are not started ART. Yes, CD4 percentage decreases even while under anti-TB treatment if the ART is also not started along with tuberculosis anti-TB treatment. Yes. Yes. This is the study done by the Tambaram Sanatorium for Tuberculosis. 39% of patients who completed a full course of regular anti-tuberculosis therapy had a recurrence in 2-year follow-up. Recurrence rate was high and was predominantly due to reinfection with a new strain of Mycobacterium tuberculosis. Yes, this is the general outcome in, in our program conditions in the program. That is, patients with HIV who are on ART having tuberculosis, and if they are treated, this is the outcome. Yes. 72% of success we can demonstrate has been demonstrated, and death occurs only in 18% of total number of cases. Yes, this graph again depicts the green line shows increased survival if the patients are started ART also along with anti-tuberculosis drugs. So what is the role of ART in tuberculosis? ART prevent reactivation of latent tuberculosis in HIV infected, reduce short-term and long-term morbidities and mortality, reduce recurrent tuberculosis. So this is how rifamycin interact with other drugs. The rifamycin stimulate the cytochrome P450 system, which also metabolizes the protease inhibitors and non-nuclease reverse transcriptase inhibitors. So rifamycin significantly reduces the bioavailability of the navirapine and the concentration minimum to subtherapeutic levels in 62% of patients. Protease inhibitors and non-nuclease reverse transcriptase inhibitors can enhance or inhibit this system, leading to altered blood levels of rifamycin and many other drugs. Yes, is it necessary? Yes, these are the common ART drugs started as a first line in patients with HIV and tuberculosis. Yes, this is the regime 1 where sidavudine, lamivudine and efavirenz, and regime 1A we start abacavir instead of sidavudine when the hemoglobin is less than 9 grams. Yes. So whenever a patient comes with pulmonary tuberculosis and HIV, irrespective of the CD cell 4 count, ART may be started. ART can be started. And the ART is, recommended ART is efavirenz containing ART regime. But the antituberculosis treatment should be started first. And ART can be started as soon as possible, that is after 2 weeks, but within 2 months of antituberculosis, intensive phase of antituberculosis therapy. In extrapulmonary tuberculosis also, irrespective of the CD4 count, we can start the efavirenz containing ART regime. Again here the antituberculosis treatment should be started first, and the ART can be started as soon as the patient can tolerate the ART, that is after 2 weeks, but within 2 months after starting the antituberculosis treatment. Yes. So this is that we can skip case scenarios. Yes. Yes. This is iris. This is a known HIV TB patient was initiated on D40 3TC and efavirenz regime after 2 weeks of category 1 of antituberculosis treatment. 4 weeks after initiating antiretroviral therapy, patient was presenting with fever, loss of appetite and dyspnea. Can you identify the cause from comparing the X-rays? Yes, here you can see the mediastinal widening with cardiomegaly. What is it due to? Yes, this is due to iris, immune reconstitution inflammatory syndrome. TB is the most commonly recognized opportunistic infection manifesting as iris after initiating ART. This is associated with restoration of tuberculosis reactivity, that is delayed type of hypersensitivity. If patients who were initially manto negative may become positive at this time, with rapidly increasing CD4 cells after ART initiation. Most common symptoms include fever, cervical lymphadenopathy and intrathoracic lymphadenopathy. The mean onset of symptoms is 2 weeks and the duration of symptoms may be 3 weeks. This is not necessary. Yes, and this rifamycin can be substituted with rifabutin for the duration of TB treatment in patients living with HIV and tuberculosis who are on second line ART. And again, supervised treatment is required. And rifabutin dose is 150 mg 3 times a week. So MDR TB, what is? Many times we can come across patients showing resistance to the first line anti-tuberculosis drug. They are called multi-drug resistant tuberculosis if the organism that is cultured is insensitive both to rifamycin and isoniazid. If the resistance extends to fluoroquinolones also, or a, a or a second line or an injectable second line antituberculosis drug, that is conomycin or streptomycin, we call them as extended MDR tuberculosis. Extended MDR tuberculosis. The drug resistant patients with MDR TB may be started on the second line anti-TB agents like amikacin, moxifloxacin, cycloserine, ethionamide or prothionamide, or PAS. Why MDR is more common in patients with HIV? Delay in the diagnosis of tuberculosis in HIV patients is not uncommon, and drugs like isoniazid and rifamycin may not be absorbed enough, and it makes the treatment ineffective, leading to acquired MDR TB. Mycobacterial persistence after treatment and relapse rates are quite high. A significant proportion of them recur with the drug-resistant mutants. Primary drug resistance in tuberculosis patients with HIV disease is common. Nosocomial MDR TB is quite possible in hospitalized patients. Yes. Yes. Is MDR TB common among patients living with HIV? Yes. MDR TB is more common in patients living with HIV than the patients without HIV infections. But the exact data is not available at present with us. And this is the MDR TB among HIV patients in India. This is a scenario. The primary multi-drug resistant tuberculosis is 4.2%. And the acquired MDR TB is more common, that is 13 to 19%. Among the patients having multi-drug resistant tuberculosis. Multi-drug resistant tuberculosis suspects are referred for culture and drug susceptibility testing, and yes, so we should suspect an MDR TB in patients failed to category 1 treatment, patients on category 2 treatment but continue to have sputum smear positive at the end of 4 months. Yes, and the management plan is DOTS plus protocol. Yes. So the time is up. We shall rush up. Yes. Yes. How there is a few words about prevention of tuberculosis. Many times tuberculosis is asymptomatic in children in patients with HIV. If we suspect a latent tuberculosis infections in patients with HIV, we can start a prophylactic therapy, especially with isoniazid at the dosage of 300 mg for 6 months, or in children 10 mg per kg per day for 6 months. Other regimes containing rifamycin also have been shown effective. Combined efficacy of isoniazid prophylactic therapy for all regime is there is 36% reduction in TB incidence. The feasibility studies are necessary before considering its introduction in the program conditions. But what are the challenges for IPT? The identification of latent tuberculosis infection is not inbuilt in our national TB program. Active TB has to be ruled out before initiating a INH prophylactic therapy. Currently, sputum smear microscopy and chest radiography are the only diagnostic tools available in our program, and they have their own limitations. Ruling out of active TB in extrapulmonary organs before initiating INH prophylaxis is a very difficult task. Primary drug resistance to isoniazid is an important issue. Difficulties in ensuring to ensure the treatment adherence also is difficult. Yes. 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 So, these are the key points at the end of the sessions I have to emphasize. TB is the commonest opportunistic infection and co-infection in patients with HIV in India. Early identification of HIV and tuberculosis by the effective cross-referral system is the key. HIV-TB co-infection has to be treated with anti-tuberculosis treatment and ART as per RNTCP and NACO guidelines for better outcome. Early initiation of antiretroviral therapy is certain to reduce the mortality, morbidity, and the incidence of new TB cases. Interactions between anti-TB drugs and antiretrovirals have to be kept in mind while managing this dreaded co-infection. Thank you. And I also thank the NACO for providing the slides for this program. I also thank our ART medical officer, senior medical officer, Dr. Suresh, who has helped very much in preparing the slides, and the Anwar from the ITech. Thank you. இவ்வளோ கொஸ்டின் இருக்காமா? இது ஆன்சர் பண்ணுமா? எத்தனை கொஸ்டின்? Yes. The skin manifestation I have seen is lupus vulgaris, where there is apple jelly like nodules seen in face and the neck. Sometimes the subcutaneous nodules may enlarge, they may go for suppuration, and they may discharge through the skin as sinuses, discharging sinuses. They are called as scrofloderma. They are called as scrofloderma. And significance of Mantoux test in adult. Mantoux reveals the immune status of the patients, whether they are able to establish an immune resistance to tuberculosis. Delayed hypersensitivity reaction, that is cell mediated, it indicates the cell mediated immunity present in the patients. But patients with HIV, the Mantoux test is not reliable. Many times it's negative, and if it is more than 5 millimeters positive, 5, hello?
Yes, Mike.
Yes, if it is more than 5 millimeters positive in HIV patients living with HIV who were already given BCG vaccination, we can take it as positive, and sometimes some authors say the mantle should be more than 10 millimeter if they are already given BCG vaccination. But many times the mantle results are unreliable in patients with HIV infection. Yes, the dosage of pyridoxine I am not very sure at present. Yes. The dosage of rifabutin is 300 milligram per day, but the rifabutin in children has not been established, and we have not yet started that.
Ask them to
Yes,
close.
vitamin D supplementation is yes. Vitamin D supplementation will definitely help in patients with patients living with HIV also. Yes.
Okay, okay.
Yes. Yes. What is the treatment for iris after starting ART? Yeah, answered. Yeah. Yes, gene expert, the cartridge-based nucleic acid amplification test. We can study the resistance to rifamycin, and the rifamycin resistance can be studied through this gene expert. Yes. Thank you. Yes. Thank you.
Thank you, sir. Thank you for the valuable session. The next session is on 25th March 2015, and then the topic will be circulated shortly. The presenter is Dr. Mamta Manglani.